Okay, thank you very much. Good afternoon, good morning here in Toronto. I am Joana Dos Santos, a medical urologist at the Hospital for Sick Children, and we'll discuss differentiating and managing primary versus secondary nocturnal enuresis. I'd also like to thank Dr. Young for an excellent talk. It's frozen. There we go. So we are going to go a little bit back to the basics and discuss the definition, classification, differential diagnosis, and red flags, right? I think that's the core of the talk. When we should think that enuresis is not caused by a primary issue of the bladder and the brain, but they're actually organic underlying causes. The current management of enuresis as well. So enuresis is defined as episodes of urinary incontinence during sleep in children older than 5 years of age, as per ICCS. And it should differentiate primary versus secondary. So primary basically means that that child was never dry for more than 6 months. And secondary means that the child was dry for more than 6 months and all of a sudden starts wetting the bed. Monosymptomatic, you have no associated daytime LUTs or lower urinary tract symptoms. And non-monosymptomatic means you have associated daytime symptoms, not necessarily daytime incontinence, but any LUTs. Frequency, urgency, hesitancy, any symptoms. So what is the importance of differentiating monosymptomatic versus non-monosymptomatic, right? So even mild daytime LUTs are common in kids with enuresis, affect up to 2/3 of them. And when present, LUTs should be addressed first, or those children won't stop wetting the bed. Right, and to differentiate both, you need to elicit the presence of daytime symptoms from the child and family, because in many cases they won't bring it up to you, right? So, one way to facilitate finding out or identifying daytime LUTs is using a validated questionnaire that we commonly use, the DVSS or the Vancouver score. In terms of primary versus secondary, so we need to ask the question if the child was ever dry for more than 6 months, and if the answer is yes, is no, so the child has primary enuresis, and we're less concerned if the answer is yes, the child has been dry for more than 6 months, we start getting concerned with an underlying cause, right? Primary enuresis, as Dr. Young just discussed, happens due to a delayed maturation between the brain and bladder axis, those children, they have sleep arousal issues, nocturnal polyuria, and a small bladder capacity, while kids with secondary enuresis, we need to rule out common organic comorbidities, then less common but serious medical conditions, and psychosocial stressors. Primary enuresis happen in up to 15% of kids up to age 5, 10% of 7-year-olds, 5% of 10-year-olds, and 2% of adults. And we hypothesize that that prevalence can be even higher, right? It's just that people don't talk about it. And there is a strong genetic link with chromosome 13 being identified as the genetic loci of primary enuresis. So if one of the parents had bedwetting up to a later age, you have a more than 50% chance of having the offspring with bedwetting as well. In terms of ruling out common comorbidities in secondary enuresis, by far the most common comorbidity will be constipation. So it's very important to identify and treat constipation. In many instances, just by treating constipation, primary enuresis gets better. And if you don't treat the constipation, the enuresis will take longer or become refractory to treat. A second common complication not listed here will be urinary tract infection. And another one will be developmental psychiatric conditions such as ADHD. Several studies have shown that if ADHD is not treated, enuresis is also refractory to treat. Ultimately, it's important to rule out upper airway obstruction, such as obstructive sleep apnea. Many studies have been shown the relationship between OSA and enuresis and refractory enuresis. And once tonsils are removed in those patients, enuresis typically gets better. In terms of less common medical conditions, but serious to consider, we need to think about diabetes mellitus, diabetes insipidus, chronic kidney disease, sickle cell anemia, hyperthyroidism, spinal dystrophism, neurogenic bladder, and more rarely, seizure disorders and cardiac arrhythmias. In terms of the 4 initial diagnoses in this list, a simple urine analysis may be very telling as a screening test, right? So a child with diabetes mellitus will invariably have the presence of glucose in the urine analysis. A child with diabetes insipidus, CKD, and sickle cell anemia and enuresis will certainly have a low specific gravity, showing a very poor concentration capacity of the renal tubules and medulla. So that's why the urine analysis is a worthwhile screening test to do. Mind you that kids with diabetes, especially diabetes mellitus, will have other symptoms, right? So it can present, enuresis can present as a first sign or symptom of diabetes, but typically they will have weight loss, increased appetite, thirst, so they are invariably very thirsty. You do have lethargy, decreased energy. Patients with diabetes insipidus, they have very large urinary volumes, not only at night, but throughout the day, and incredible thirst. Patients with CKD will have other associated signs and symptoms as failure to thrive. They can have lethargy as well, change in appetite and things like that. And sickle cell anemia, we'll know, at least in Canada, that's a disease that's picked up in the newborn screening, and they will have other manifestations such as pain crisis, anemia, etc. In terms of cardiac arrhythmias being an underlying cause for enuresis, this is a very interesting case report published last year. It's actually a young and healthy female that had 2 episodes of unexplained bedwetting 2 years apart, one at age 18 and 20 years of age, previously dry, never had bedwetting. She did not have any other symptoms. She did not take any medications, no alcohol, no illicit drugs. She had normal urine tests, normal ultrasound. And very sadly and tragically, this young girl passed away at age 23 during this leap. Digging into history, she had a positive family history of sudden death at young age. With this context of her passing away and the positive family history, her mother got an ECG, and the mother's ECG showed prolonged QT. So this girl unfortunately passed away with congenital long QT syndrome. Why did I choose this case? Not that I'm suggesting doing an ECG for every child with secondary enuresis, but in the context of secondary enuresis, especially sporadic cases, it's worthwhile asking the history. And if there is a history of sudden death in the family, it's worthwhile ordering an ECG. So tailoring and individualizing investigations and treatment is absolutely necessary, and I agree with Dr. Young in that point. It's also important to think about and rule out and treat psychosocial stressors that could be a cause of secondary enuresis, such as child maltreatment or abuse, trauma, and bullying. In terms of history for enuresis, it's very important to get a detailed history of the enuresis per se, such as frequency, severity, and the impact of enuresis, because if that child, if it's primary enuresis, the child's not really bothered by it in a relatively younger age, 5 or 6 years of age, you may not treat. However, if it's an older child, you approach differently and you are more aggressive and early in investigations and treatment. A child that has overnight urine volume of more than 130% of expected blood capacity has nocturnal polyuria, and that has treatment implications. So that child is likely to respond to the alarm and is more likely to respond to the JVP. So it's very important to get a detailed enuresis history. And we know that enuresis that occurs every night is less likely to respond right away or to resolve spontaneously and may require more treatment as well. It's important to ask about a detailed fluid intake history, quantity and timing. Kids with enuresis tend to drink less during the day and more at night, and that results on nocturnal polyuria. In terms of physical exam, height and weight, look for enlarged tonsils, a history of snoring, back exam, lower limbs, especially motor and sensory exam and gait, looking for an underlying spina bifida or neurogenic reason, and the abdominal exam may reveal constipation. However, as you know, most cases of primary or secondary enuresis, kids will have a completely normal physical exam. In terms of investigations, not much needs to be done other than urine analysis. And if you are 100% confident you have monosymptomatic primary enuresis, you don't necessarily need to do urine analysis right away. The ultrasound is rarely indicated, except for cases that you have associated daytime symptoms, hesitancy, poor emptying of the bladder. In that case, doing a screening ultrasound is indicated, and always avoiding diarrhea, including measured urinary volumes. The management of primary monosymptomatic enuresis, the mainstay is education and reassurance, knowing that that will go away over time, just don't know when. So if the child is not bothered by the enuresis, this may be the recommended initial approach, education, reassurance, if most behavioral changes. But if the child is bothered by it, regardless of the age, if self-esteem is affected, and for families who are distressed by bedwetting, then behavioral strategies, the bedwetting alarm, medication, alternative therapies should be discussed, and always with no blame or judgment. Behavioral strategies include optimal avoiding practices, including during the day, so time avoiding every 2 hours. The food intake should be the appropriate for the child's age and weight. However, 80% of this food intake should be taken up to 4 p.m., 20% after 4 p.m., no fluids 2 hours before bed. Diet and nutrition to avoid constipation, and positive reinforcement for things that the child has control over. So positive reinforcement if they pee before going to bed, if they're doing their peeing every 2 hours, but not positive reinforcement for dry nights because they have no control over it. In terms of active therapies, earlier consideration, certainly for older children and adolescents when bedwetting has a higher impact in quality of life, and always address LUTs and comorbidities first. The bedwetting alarm is certainly the gold standard for primary enuresis, secondary enuresis without underlying organic causes. The conditioning system, as you know, improves the arousal, inhibits the micturition reflex, and improves the reservoir. There's a 60 to 80% response to the bedwetting alarm if applied to the right child at the right time when they're motivated to do so. There is, however, up to 50% relapse. You consider success more than 14 consecutive days of dryness, and that's when you can stop using the alarm. And treatment should be discontinued if there is noticeable improvement, if there is no improvement for 6 weeks. DGAVP, melts or tablets available in Canada, we no longer have the inhaled DGAVP. It's indicated for intermittent use for camps and sleepovers. There is up to a 70% relapse after discontinuing, and can be used as a second line of treatment. We typically prescribe for 3 months in a row, and then we'll stop. Common side effects will be abdominal pain, rarely water intoxication, but we always recommend patients to stop drinking 1 hour before taking the DGAVP, and don't drink anything for 8 hours for the entire night. As a third line of treatment, we do associate anticholinergics to DGAVP, as Dr. Young also discussed. And in cases with underlying overactive bladder, we may do mirabegron as well instead of oxybutynin, especially if they have constipation. And we rarely use tricyclics or amitriptyline due to low rate of success and high toxicity profile, including cardiotoxicity. Other therapies to consider to refractory cases will be transcutaneous neurostimulation and sacral neurostimulation. And in those cases, we typically order a urodynamics first, a urodynamics and a spine MRI before considering SNS. Thank you very much. I remain here at your disposal for any questions. And here is my email if you guys have any questions as well.
Thank you, Joana. We will ask the audience if there are any questions.
Yes, just to ask about this oral vasopressin. So what time does she prefer? So Joana, how do you prefer? What time do you prescribe this milk? Does it have any interaction with the food?
Sorry, I'm not sure if I could hear the question completely. I understand your question is what time do children take the DDAVP?
So what should be the time gap between the dinner as well as this administration of the tablet?
The tablet. So we typically recommend the melt because they don't need the water to take the tablet, and they take 1 hour before bed.
1 hour before that.
Yeah, 1 hour before bed, and you need to stress that they should not drink water for 8 hours after taking it.
Regarding mirabegron.
Oh, mirabegron.
Consider adding mirabegron to your table.
Yeah, so if you have underlying overactive bladder, so it's non-monosymptomatic enuresis, that child has urgency and frequency during the day. It's not responding to conservative treatment, so not responding to bladder retraining and constipation management after 6 months. In that case, we associate mirabegron.
What would be the youngest age at which you would use mirabegron, or there is no age, lower age limit consideration?
Yeah, so the FDA approved mirabegron for kids older than 4. We have been using in kids older than 2, but in this context of enuresis, we only consider enuresis an issue after 5 years of age, right? So we use in kids older than 5, but it has been approved by FDA for kids older than 4.
Thank you.